Hi, good afternoon, doctors. Today we are on a 19th day of reading Oxford Handbook of General Practice. I'm Dr. Sesha, your study buddy, and we are studying together for MRCGP International AKT exam. And today our topic of discussion will be renal medicine and urology, page number 428 onwards. Let's start reading. Urinary tract obstruction. Causes of obstruction is given page 13.2. Obstruction may be unilateral, kidney, pelvic, pelvic-ureteric junction or ureter, or bilateral, bladder, urethra and prostate. Unilateral obstruction may present late if other kidney remains functioning. So suspect if loin ache is worsened by drinking, confirm with ultrasound and refer to urology. Obstructing lesions may be in the lumen, example the stones, in the wall, example the tumors, or impinging from outside, example the retroperitoneal fibrosis. Acute retention of urine. Sudden inability to pass urine, lower abdominal discomfort with inability to keep still. Differentiate from an acute kidney injury. And this is retention, so you have to differentiate it from acute kidney injury. Males more than females, risk factors more than 70 years, symptoms of prostatism or poor urinary stream would be present. Causes are prostatic obstruction, 82% of the cases, constipation, alcohol causes acute urinary retention, anticholinergics, drugs like anticholinergics and diuretics also will cause retention, UTI, operation, example a hernia repair. Rarer causes are urethral stricture, clot retention, spinal cord compression and bladder stone. Examination. Abdomen, there will be a palpable palpable bladder, and direct rectal examination, there is enlarged plus or minus irregular prostate, perineal sensation to exclude neurological cause. So you have to exclude any neurological cause. For that you have to check whether there is sensation in the perineum or not. So if there is no sensation in the perineum, then you have to check for any neurological causes of urinary retention. Investigation. Midstream urine to exclude an infection. Blood for urea and electrolytes, creatinine, EGFR, only to differentiate it from AKI. Only investigate if catheterizing in the community. So if you want to catheterize, then only you have to do the investigations. Management. Catheterize. Record initial volume drained or refer to urology for catheterization. Local policies vary. Treat infection. Refer to the DN for instruction on management of the catheter. Refer to urology for further assessment and treatment. Chronic retention of urine. Incidence onset causes are benign prostatic hypertrophy, pelvic malignancy, CNS disease, may present as nocturnal enuresis, acute or chronic retention, acute on chronic retention, UTI, overflow incontinence, lower abdominal masses, renal failure. Examination and investigation. As per acute retention, bladder is enlarged, may contain 1.5 liters or more, but usually non-tender. Management. Refer to urology for further assessment and treatment. Refer urgently or acutely if pain, UTI or renal failure is present. Do not catheterize in the community. So, chronic retention, do not catheterize in the community. You need to refer for urology assessment. Retroperitoneal fibrosis. Ureters have become embedded in the dense fibrous plaques in the retroperitoneal space. Associations are drugs like methotrexate, carcinoma, Conn's disease, connective tissue disease, Raynaud's syndrome, fibrotic diseases, example alveolitis. Presentation and management. Typically, middle-aged men presenting with fever, malaise, sweating, leg edema, increased BP, palpable mass, and acute or chronic renal failure. So, this is the presentation of retroperitoneal fibrosis. So, here there is fever, malaise, sweating, leg edema, or raised BP, palpable mass, or acute or chronic renal failure. Refer for a specialist care. Options include steroids and nephrostomies. Horseshoe kidney. Congenital abnormality. Kidneys are fused in a midline to form a horseshoe-shaped mass. The kidney may function normally or may present with obstructive nephropathy or UTIs. So this is the figure, causes of obstruction, unilateral and bilateral. Unilateral is pelvic-ureteric junction. There might be a tumor or a calculus. Ureter, unilateral ureter causes are calculus. There can be a tumor, impacted sloughed papilla from here. and retroperitoneal fibrosis more on one side, compression by the lymph nodes on one side. If both the ureters are involved in retroperitoneal fibrosis, bladder cases like tumor, there is a tumor in the bladder here where both the there is obstruction of both the sides, and there's a clot or a pelvic malignancy compressing this bladder outflow and causing obstruction, pelvic malignancy or a calculus obstructing anywhere down beyond the ureters. In the bladder, there could be a tumor unilateral or a clot on unilateral side, or a pelvic malignancy or a calculus which is more on one side. So that can cause a unilateral obstruction even when there is a bladder pathology. Prostate pathology, benign BPH and a prostate cancer will cause bilateral pathology, bilateral obstruction. Urethral stricture and urethral walls will cause obstruction in both sides. Causes of urinary tract obstruction. That was in the figure. Passing a urethral catheter. Technique learned through supervised experience. Only attempt alone if you are competent to do so. Prepare the equipment needed. Sterile rubber gloves, plastic sheet to prevent spills, paper sheet to provide sterile field, cleansing materials, cotton swabs, cleansing fluid, local anesthetic lubricant gel, 1% lidocaine plus or minus, plus 12.25% chlorhexidine. Catheter, usually a 12 ch or a 14 ch. Ensure the catheter is long if catheterizing men, and if the catheter is not pre-filled, then sterile syringe plus 10 ml of sterile water is required. Kidney dish or other receptacle to catch the urine before connecting the drainage bag, draining the tube and the bag. Inserting the catheter. Ensure the patient is comfortable. Protect against spills with plastic sheet and cover the area with a sterile paper sheet. Ensure strict aseptic technique. Cleanse the penis and vulva and squeeze the lubricant or local anesthetic gel into the urethra. Allow it to work. Gently but firmly push the catheter into the urethra. Ensure the end of the catheter is over the receptacle. When the catheter enters the bladder, urine flows into the receptacle. Inflate the balloon with sterile water if needed once the catheter is inside the bladder. Connect the catheter to the collecting tube and the bag. If a male, pull the foreskin over the glands again to prevent paraphimosis. If you are unable to pass a catheter, refer to urology. BPH or benign prostatic hypertrophy. 10 to 30% of the men are in their early 70s have symptoms of BPH. There is no relation between the size of the prostate and the symptoms. Assessment, table 13.9, symptoms of prostatism. Obstructive and obstructive and intermittent urinary stream, double micturition, hesitancy, terminal dribbling, feeling of incomplete emptying, and straining to void. Differential diagnoses are prostatic enlargement or strictures, tumors, urethral walls, bladder neck contracture. Irritative causes due to detrusor muscle hypertrophy, urinary frequency, urgency, dysuria, and nocturia. Differential diagnosis includes an enlarged prostate, UTI, polydipsia, detrusor instability, and hypercalcemia or uremia. Complications 10% at presentation. Recurrent UTIs, bladder stones, hematuria, acute retention of urine plus prior obstructive symptoms. Chronic obstruction, overflow incontinence, and obstructive nephropathy. GP management. Symptoms can improve spontaneously but overall progress slowly. 1 to 2% per year develop a urinary retention. Options are watchful waiting. Patient with mild or moderate symptoms at presentation with no complications of BPH and who are not severely troubled by the symptoms. Self-help includes decreasing the evening fluid intake, decreasing the caffeine intake, bladder retraining, and prevention of constipation. Drug therapy. Those with mild or moderate symptoms who are troubled by the symptoms, consider alpha adrenoreceptor agonist, example prazosin, doxazosin. Watch for postural hypotension, reduction of decreased symptomatic worsening. So the drugs which are used for BPH are alpha adrenoreceptor agonists like prazosin or doxazosin, and 5-alpha reductase inhibitors, finasteride. Best for patients with bulky prostate, takes up to 6 months to work, decrease the risk of urinary retention. Combination therapy, 5-alpha agonist and 5-alpha, alpha adrenoreceptor agonist and 5-alpha reductase inhibitors decrease the progression by 66% more than either agent alone. Referral to a urologist. Emergency admission, urgent, soon and routine. Complicated BPH, that is acute retention, emergency or urgent referral. Raised PSA is an urgent referral. Nodular firm prostate on DRE is an urgent referral. Several severe symptoms is a soon referral. Failure to respond to drug therapy after 3 to 12 months of alpha blocker or 6 to 12 months of 5-alpha reductase inhibitor is a routine referral. Bacterial prostatitis. Consider in men presenting with suspected UTI. Other features are fever, arthralgia, myalgia, low back pain, perineal or penile or rectal pain. DRE reveals swollen tender prostate. If suspected, check MSU and treat with paracetamol or ibuprofen plus codeine and 4-week course of oral antibiotic which penetrates prostatic tissue. Example, ciprofloxacin 500 mg BD, ofloxacin 200 mg BD. So, in case of bacterial prostatitis, the drug of choice will be ciprofloxacin 500 mg BD or ofloxacin 200 mg BD for a 4-week course. It is not a short course, it's a 4-week, that is 1 month course of antibiotics. Refer for specialist advice if not settling. Complications include acute retention of the urine, chronic bacterial prostatitis or prostate abscess. Assessment of BPH. History. General well-being. Ask for general well-being, obstructive symptoms, irritative symptoms, hematuria, pain, polyuria and polydipsia, neurological symptoms, past history of urological instrumentation or STIs. Frequency volume chart. Assess the pattern and type of fluid consumption, example alcohol or caffeine at night or nocturia, increased nocturia. Symptom score. Objectively grade the symptoms, measure the severity. IPSS is the score that is used for measuring the symptoms of prostate BPH. Scores 0 to 7 is mild, 8 to 19 is moderate and 20 to 35 is severe. A general quality of life measurement can be used to assess impact of symptoms. Abdominal examination. Look for distended bladder, palpable kidneys, examine the external genitalia. Digital rectal examination. Look for the anal tone, the size, shape and consistency of the prostate. Normal prostate, the size of a chestnut. Normal prostate is the size of a chestnut with smooth rubbery consistency. Serum urea, creatinine and EGFR. Renal function assessment. MSU, a dipstick for blood and glucose and microscopy, culture and sensitivity. Ultrasound measurement of post-micturition residual urine. Maximum voiding flow less than 15 ml per s for voided volume. More than 100 ml is abnormal. Maximum voiding flow rate less than 15 ml for voided volume and more than 100 ml is abnormal. Serum PSA. High values can indicate a prostate cancer. May be available through open access prostate assessment clinics. Chronic prostatitis or chronic pelvic pain syndrome. 2 to 4% lifetime prevalence, cause is unknown. Patients with more than 3-month history of urological pain, lower abdominal, pelvic or perineal pain, penis, tip or on ejaculation, testicles, rectum or low back pain, irritative or obstructive symptoms or ejaculated disturbance. Diagnosis is based on history with exclusion of other causes. Suitable investigations include a direct rectal examination, midstream urine sample, urine cytology, sexually transmitted infection screen, PSA plus urodynamic studies. Treatment is difficult and provide information and support. Try alpha blockers, doxycycline 4 mg OD for 6 months. Spontaneous improvement or remission often occurs. So for further management, you have been given references. 432. The International Prostate Symptom Score, IPSS score, which we have seen less than 7 is mild, 8 to 19 is moderate, 20 to 35 is severe. So in this, what does it count? See, what all things are considered in the score. Over the past month, how often have you had a sensation not emptying your bladder completely after you finish urinating? Over the past month, how often have you had to urinate again within 2 hours after you finish urinating? Over the past month, how often you have stopped or started several times when you urinated? Over the past month, how often have you found it difficult to postpone urinating? Over the past month, how often have you had a weak urinary stream? Over the past month, how often do you had to push or strain to begin urinating? Over the past month, typically from the time you went to bed to the time you got up in the morning, how many times did you get up to urinate? If you were to live the rest of your life with your urinary condition the way you feel it now, how would you feel about it? So this was the questionnaire. And 0 to 7 is mild symptom, 20 to 35 is severely symptomatic, 8 to 19 is moderately symptomatic. International Prostate Symptoms Score. Prostate Specific Antigen Testing, PSA. There is no prostate screening program in the UK, but men can request a PSA test. The government has introduced PSA Informed Choice program, warn the patients about the full specificity of the test before performing the test, and provide information about the pros and cons of testing. In addition, the PSA is routinely measured in men with urological symptoms. Abnormal PSA is a common reason for referral to urologist. Its sensitivity and specificity are poor. Pros and cons of PSA testing. Benefits of PSA testing and downside of PSA testing. Benefits are, it may provide reassurance if the test result is normal. It may find cancer before symptoms develop and at an early stage when treatment could be beneficial. If the treatment is successful and the consequence of more advanced cancer are avoided. Downside is, it can miss a cancer and provide false reassurance. It may lead to unnecessary anxiety and medical tests when no cancer is present. It might detect slow growing cancer that may never cause any symptoms or shorten lifespan. The main treatments of prostate cancer have significant side effects and there will be no certainty that the treatment will be successful. Reasons for raised PSA. It could be prostate cancer, BPH, acute or chronic prostatitis, physical exercise, acute urinary retention, prostate instrumentation like prostate biopsy or urinary catheterization, and old age. Other reasons for raised PSA. PSA may be normal when an early prostate cancer is present. Performing a PSA test. Distal rectal examination may cause an transient increase in PSA levels, so do the PSA test before doing the DRA. If that is not possible, delay the test for 1 week after examination. Exclude urinary infection before testing PSA. Do not do a PSA test if the man has a proven UTI. Treat the UTI and postpone the PSA test for more than 1 month. So in case of an DRA, you have to postpone the test for 1 week. In case of a UTI, postpone the test for 1 month. Ejaculated within the previous 48 hours, do not do a PSA test. Exercised vigorously in the previous 48 hours, had a prostate biopsy less than 6 weeks ago, do not do the PSA test. PSA cutoffs that should prompt referral are age 50 to 59, more than 3.0. Refer to urology if PSA is in 50 to 59 years age group. If it is more than 3, in 60 to 69 years age group, it's more than 4, and more than 70 years age group, it's more than 5. Finasteride and dutasteride decrease the PSA by around 50%. Prostate cancer. Prostate cancer is the 6th most common cancer worldwide. It's the most common cancer affecting males, up to 26% of all male cancer diagnoses, and 10,000 men per year die from the disease in the UK. 1 in 6 men have clinical prostate cancer in their lifetime, and the incidence is rising. Classification. Non-metastatic prostate cancer can be divided into clinically localized disease, cancer thought after clinical examination to be confined to the prostate gland. Locally advanced disease, cancer that has spread outside the capsule of the prostate gland but has not yet spread to other organs. Metastatic prostate cancer. One is non-metastatic and metastatic. Cancer that has spread outside the prostate gland to the local, regional or systemic lymph nodes, seminal vesicles or other body organs like bone, liver and brain. Risk factors are age, uncommon less than 50 years, 85% are diagnosed more than 65 years of age. Genetic, increased incidence if first degree relative is affected. Racial, incidence varies according to the location of in the world and ethnic group. Highest rates are found in men of black ethnic group in USA, lowest in Chinese men. Dietary, links are proposed between prostate cancer and low intake of fruit, particularly tomatoes, and high intake of fat, meat, and calcium. Screening. There is currently no screening program in the UK. Problems with screening are incidental postmortem evidence of prostate cancer is high. 75% men more than 75 years. Very few become clinically evident. So many more men would be found with prostate cancer by screening than would die or have symptoms from it. Natural history of prostate cancer is not understood. There is no means to detect which early cancers become more widespread. Inadequate screening tests. It is not clear if early treatment enhances life expectancy. Peak incidence of morbidity and mortality in old age, 75 to 79 years. So, potential years of life saved by screening are small. So, screening is not advised here. Screening tests are PSA, digital rectal examination. It is operator dependent, fails to detect early prostate cancers and lacks specificity. Annual screening in the US and Germany has not reduced the mortality. Transrectal ultrasound, too expensive. The most effective screening regimen involves rectal examination and PSA testing followed by TRUS for suspicious lesions. The optimal screening interval is unknown, but serial screening does increase detection. Symptoms and signs of prostate cancer. Early cancer are symptomless, usually detected following an incidental finding of raised PSA. Hard nodules sometimes felt on the prostate on DRE. Local disease can have symptoms of prostatism, urinary retention, hematuria, lower extremity edema. On rectal examination, the prostate is hard, non-tender, and sulci loose definition. Metastatic disease, malaise, weight loss, bone pain, pathological fractures, spinal cord compression, ureteric obstruction may cause renal failure. Signs depend on the site of the metastasis. Investigations. A distal rectal examination and a PSA test after counseling are recommended for patients with any of the following unexplained symptoms: erectile dysfunction, hematuria, low back pain, any lower urinary tract symptoms, weight loss, especially the elderly, and bone pain. So you have to advise a DRA and a PSA test for any patient with the following symptoms like erectile dysfunction, unexplained following symptoms: erectile dysfunction, hematuria, low back pain, any lower urinary tract symptoms, weight loss, especially in the elderly, and bone pain. Exclude UTI before PSA testing and postpone distal rectal examination after the PSA test is done. Urgent referral. Rectal examination. There is a hard, irregular prostate typical of prostate cancer. PSA results should accompany the referral. PSA levels are greater than the age-specific reference range. Consider discussion with a specialist and the patient plus carer before referral for very elderly patients and those compromised by other comorbidities. Referral is not needed if the prostate is simply enlarged and PSA is in the age-specific reference range. 436. Treatment of prostate cancer. Symptoms or symptomless local disease. Treatment is controversial. There are two arguments. Benefits of treatment are overweighed by risks, or aggressive treatment before spread is the only way to ensure cure. More than 50% of the males more than 50 who die from other causes are found post-mortem to have prostate cancer. Prostate cancer kills only small minority of men who have it. The personal and economic cost of treating men whose cancer would have never caused them any problems must be considered. Options: watchful waiting or active surveillance, monitor with PSA and regular rectal examination. Increase in PSA or size of the nodule triggers active treatment. A large UK trial published 2016 has found active monitoring is as effective as surgery and radiotherapy in terms of survival at 10 years with less side effects. Progression rates are higher in patients with poorly differentiated cancer. and some men with the uncertainty of waiting difficult to cope with. Men find the uncertainty of waiting difficult to cope with. Radical prostatectomy. So they say that surveillance is as equivalent as surgery or radiotherapy in prostate cancer. Uh, Serial surveillance. Radical prostatectomy has a potential for cure, but in age group most affected by prostate cancer, mortality is 1.4%. The other common complications are impotence and incontinence, 25%. Radiotherapy may not be effective. Persistent cancer is found in 30% on biopsy. Brachytherapy, radioactive treatment in implanted seeds or wires, has proven efficiency in early prostate cancer. Hormone treatment, no convincing evidence that gives survival benefit in the early disease. Others are minimally invasive treatments like cryotherapy or microwave therapy. Symptomatic disease. In symptomatic disease, 30% 5-year survival is there. Hormone manipulation is the mainstay of treatment and gives 80% reduction in bone pain, PSA levels, as well as both, and lower incidence of serious complications, example spinal cord compression, if treatment starts at the time of diagnosis. Options are, what are the options for treatment in symptomatic disease are luteinizing hormone releasing hormone analogs, LH, RH analogs, that are goserelin, subcutaneous injection every 4 to 12 weeks depending on the preparation used. Testosterone levels decrease to levels of castrated men in less than 2 months. Side effects are impotence, hot flushes, gynecomastia, local bruising, infection around the injection site. When starting LH-RH analogs, LH level initially increases, which can cause increased tumor activity or flare, counteracted by prescription of anti-androgens or flutamide for a few days before administration of the first dose of LH-RH and concurrently for 3 weeks. Response in most patients lasts for 12 to 18 months. Anti-androgens, cyproterone acetate, flutamide and bicalutamide do not suppress the androgen production completely, used to prevent side effects due to testosterone flare during initiation of LH-RH analogs as monotherapy. Example, bicalutamide 150 mg and in combination with LH-RH analogs to produce maximum androgen blockade. Surgical castration. Decreased testosterone secretion permanently without the need for medication, however rarely used. Bony metastasis. In addition to the hormonal therapy, local radiotherapy and corticosteroids are used for bone pain. Radioactive strontium decreases the number of new sites of bone pain developed, mean survival is less than 5 years. Hormone-resistant disease, no agreed treatment, involved the multidisciplinary team including urology, oncology and palliative care. Dexamethasone 0.5 mg daily or docetaxel may be helpful when there is a hormone-resistant disease. Factors affecting the prognosis of prostate cancer. T1, impalpable prostate cancer. T2, N0 is no lymph nodes and M0 is no metastasis outside the pelvis. T2, tumor completely within the prostate gland. T3 is tumor has breached the capsule of the prostate. T4, spread within the pelvis, example into the bladder or into the bowel, that is local spread. N1, one positive lymph node less than 2 cm in diameter. N2, more than one positive lymph node or one lymph node of 2 to 5 centimeters in diameter. N3, any positive lymph nodes more than 5 centimeters in diameter. Metastasis, no spread outside the pelvis. M1 is spread outside the pelvis. Gleason score is used in histologic grading of prostate cancer. Cells are graded 1 to 5 in the less differentiated they are. The two areas of biopsy with the highest grade cells are added together. Low grade tumors likely to grow slowly have low scores 2 to 4. High grade tumors have high scores 7 to 10. Old age. Older patients with low grade tumors are likely to die from something other than the prostate cancer. PSA more than 40, high chance of nodal or metastatic spread. PSA more than 100, metastatic spread is very likely. Prognosis of 5-year survival rates for tumor stage 1 or 2. Stage 1 or stage 2 tumor confined within the prostate, 65 to 98% survival. Stage 3 tumor has breached the capsule of the prostate, 60% survival. Stage 4 spread to the lymph nodes within the pelvis or elsewhere, 20 to 30% survival. Further information is there in the website. 438. Conditions of the penis. Posterior urethral walls. Folds of the mucosa inhibit or block the passage of urine, causing urethral, bladder, ureter, or renal pelvis dilatation. Presentation usually detected on antenatal ultrasound. Scan can present in neonates with urinary retention or dribbling urine or distended bladder, UTI or uremia, or later in childhood with recurrent UTI or incontinence. Investigation and management. MCUG Micturating cystourethrogram confirms the diagnosis of posterior urethral walls. In all cases, refer to urology for surgical disruption of the walls. Hypospadias. 1 in 400 male births, the urethral meatus opens on the ventral side of the penis. There is often a hooding of the foreskin and ventral flexion of the penis. Refer to urology. Treated with corrective surgery, ideally preschool. Non-retractable foreskin. Usually noted by parents, may be a history of recurrent balanitis. Examination of foreskin is adherent. Management. Age less than 4 years, do nothing unless recurrent balanitis is present. If more than 4 years or recurrent balanitis, consider treatment with topical steroids. Example, betamethasone 1% OD for 3 to 4 months. If ineffective, refer to pediatric surgery for circumcision. So this has been asked again in the exam. So when there is patient is less than 4 years and asymptomatic, do nothing. If more than 4 years or they have recurrent balanitis, consider treatment with steroids, topical steroids 0.1% betamethasone for 3 to 4 months. And if that is ineffective, refer to a pediatric surgery for circumcision. Phimosis. The foreskin obstructs the flow, common in small children. Time usually obviates the need for circumcision. Treat as for non-retractile foreskin if recurrent balanitis is present. Perion's disease. Hard lumps in the shaft of the penis. Perion's disease. Unknown cause. 4% in males more than 40 years. 1 in 3 have pain, bleeding of the penis when erect, associated with erectile dysfunction. 5% have depressed contracture. Management. Reassurance usually suffices. No proven medical treatments. Refer to urology for surgery if pain or severe bending or erection so that intercourse is not possible. Paraphimosis. Foreskin is retracted because of edema unable to be replaced. Commonly occurs in catheterized patients when the catheter is changed. Management. Try to replace the foreskin using ice packs to decrease the swelling and lubrication, that is KY jelly. If unable to replace the foreskin, admit for surgery. Balanitis. Acute inflammation of the glands and foreskin. Common organisms are Staphylococcus, Streptococcus, coliforms and Candida. Staphylococcus, Streptococcus, coliforms and Candida can occur at any age, most common in young boys when associated with non-retractile foreskin or phimosis. In elderly patients, consider diabetes. Management. Oral antibiotics, example flucloxacin, or topical antifungals, example clotrimazole. If recurrent or secondary to phimosis, consider referral for circumcision. Balanitis xerotica et obliterans. Chronic fibrosing condition of the foreskin which may become adherent to the glands. Treatment is with topical steroid creams, example betamethasone 0.1%. Consider referral for circumcision. Trauma to the foreskin. Torn frenulum. Seen after poorly lubricated intercourse or if caught in a zip, no treatment is required. If recurrent, consider referral for circumcision. Erectile dysfunction. Priapism. Persistent painful erection not related to sexual desire. Cause are medication for erectile dysfunction, idiopathic, leukemia, sickle cell disease or pelvic tumor. Either due to medication, idiopathic causes, leukemia, sickle cell disease or a pelvic tumor. Management. Ask the patient to climb the stairs, arterial steal phenomenon. Apply ice packs. If unsuccessful, refer to A&D for aspiration of the corpora. Rarely surgery is needed. Erythroplasia of curate. This is a pre-malignant condition of the glands. Moist velvety looking patches are present. Refer to urology. Treatment is surgical. Carcinoma of the penis. Squamous cell carcinoma 95% of the times and malignant melanoma usually in elderly people, rare in the UK. Management. Refer urgently patients with symptoms or signs of penile cancer. These include progressive ulceration of the glands, prepuce or skin of the penile shaft, mass in the glands or prepuce or skin of the penile shaft. Lumps within the corpora cavernosa can indicate Peyronie's disease which does not require urgent referral. Penile discharge associated with urethritis due to chlamydia or gonorrhea, refer to the gum clinic. Testicular disease. Testicular pain, treat the cause. Epididymoorchitis. Testicular pain is caused by epididymoorchitis, torsion of the testis, trauma and hematoma formation, varicocele, testicular tumor, rarely painful. Epididymoorchitis, torsion of the testis, trauma and hematoma formation, varicocele, testicular tumor, really painful. Torsion of the testis. Peak at around 15 to 30 years of age, presence with sudden onset severe scrotal pain, may be associated with right iliac fossa pain, nausea and vomiting. Examination. Tender hard testis riding higher than the contralateral testis. Admit urgently to surgical or urology team. Torsion of the hydatid of Morgagni. Small embryological remnant at the upper pole of the testis present similar to torsion of the testis. Refer as an emergency to exclude torsion testis. Epididymoorchitis. Inflammation of the testis and epididymis due to infection may occur at any age. The most common viral cause is mumps. The most common bacterial cause is chlamydia or gonorrhea, less than 35 years, and coliforms more than 35 years. Chronic infection with TB or syphilis is rare. Presentation. Acute onset pain in the testis, swelling and tenderness of the testis or epididymis. Fever plus rigors may be urethritis, dysuria or increase in frequency of urination. Management may be difficult to distinguish from torsion of the testis. If it is in doubt, admit for urology or surgical opinion. Otherwise, investigate and treat for the underlying cause. Testicular lumps and swellings is present in the figure 13.3. Hydrocele. Collection of fluid in the tunica vaginalis occurs at any age. Primary hydrocele, no predisposing cause in the scrotum. Secondary hydrocele, reaction to pathology in the testis or covering infection, tumor, or its covering, either infection, tumor, or torsion. In adults, presence with a hydrocele, always consider impalpable tumor beneath. In adults who present with a wide hydrocele, consider there might be an impalpable tumor beneath. Presentation. Swelling in the scrotum. Examiner should be able to get above the swelling. A smooth surface transilluminates and testis is within the swelling and not palpable separately. Management. Investigation is not required in children. Refer adults for ultrasound testis if his testis is not palpable. Options for adults. Conservative management, reassurance, small hydroceles, tapping. May be suitable for large hydroceles where surgery is inappropriate. Secondary infection and recurrence are common. Surgery, refer to your urologist. Hydroceles in children, usually congenital, may be unilateral or bilateral. Most resolve spontaneously in the first year of life. Refer to urology if it persists beyond 1 year. Okay. Hydrocele of the cord arises as a part of the processus vaginalis in the spermatic cord above the testis. a rounded lump which slips up and down the inguinal canal. No action is needed. Can you get the mass? Can you get about this is a flow chart for testicular mass. Diagnosis of testicular lumps. So let us see stepwise. Can you get above the testicular mass? Yes. Is it cystic? Yes. Is it separate from the testis? Yes. Differential diagnoses are, it could be an epididymal cyst or it could be a spermatocele. In the case it is not separate from the testis, no. The testis lies within the swelling. The differential diagnosis could be hydrocele if it translaminates, hematocele if it does not translaminate. In case it is not a cystic mass, it's a solid mass and it is separate, is it separate from the testis? If it is the yes, then differential diagnosis could be acute or chronic epididymitis, torsion of the hydrotroph Morgagni. If it is not separate from the testis, then it could be a tumor, orchitis, torsion or a gamma. Tumor, orchitis, torsion, testis or a gamma. And when you go for the first question, if you can get above the mass, is yes, then the mass is separate from the testis, and no, you are not able to get above the mass. Differential diagnosis could be a inguinal hernia extending into the scrotum, a varicocele, or a hydrocele of the spermatic cord. Any acutely painful scrotum should be treated as a torsion of testis unless proven otherwise. So if you can get above the mass, that means the mass is testicular origin. If you are not able to get above the mass, then it is originating in the inguinal canal or into the abdomen and just passing down into the testis, like varicocele and hydrocele of the spermatic cord. Referral guidance for a testicular mass. If urgently patients with swelling or mass in the body of the testis, consider an urgent ultrasound in men with a scrotal mass that does not transilluminate or when the body of the testis cannot be distinguished. Hematocele. Damage to the testis, example. Damage to the testis, example, due to a direct blow, vasectomy, can result in testis rupturing and the tunica vaginalis filling with blood. Refer as an emergency for urological assessment. Varicocele is collection of varicose veins in the pampiniform plexus of the cord and the scrotum. Can be secondary to obstruction of the testicular veins in the abdomen. Left is more than right, associated with infertility, thought to be due to increased temperature of the testis. Presence with a dull ache in the testis, especially at the end of the day or after exercise, usually visible when patient is standing. No treatment is needed. Reassure. Occasionally, surgery or radiological embolization may help if symptoms are severe. Epididymal cyst. Common and often multiple, found in middle-aged elderly man, usually presents with patients when the patient finds a painless lump. Examination is smooth-walled cyst in the epididymis, palpable above and below, behind the testis, often bilateral. Investigations, if unsure of the diagnosis, refer for an ultrasound. And management, reassurance, refer to urology if it is painful. Spermatocele is a cyst containing sperms, typically situated in the head of the epididymis, more rarely in the spermatic cord. Clinically presents in the same way as an epididymal cyst and management is the same. Testicular gumma 725. Benign testicular tumors. Rare, less than 2% of the tumors. Sertoli cell adenomas, Leydig cell adenomas produce sex hormones and cause feminization, example masculinization respectively. So, Sertoli cell adenomas cause feminization and Leydig cell adenomas cause masculinization. Refer testicular cancer. Most common malignancy in men aged 20 to 34 years. Devastating disease as sufferers tend to be young and fit and do not expect to be ill. Screening is not effective. Education to ensure men check their testes for lumps regularly and present as early is preferable. Risk factors: undescended testes, bilateral undescended testes, more than 10 times increased risk, past history of testicular cancer, 4% risk of a second cancer. Presentation: painless lump in the testes, occasionally a testicular pain or can present as a painless lump in the testes, occasionally by testicular pain or hydrocele, may present with metastasis, back pain and dyspnea. Management: testicular lumps are tumors until proven otherwise. Refer for urgent urological opinion. Ultrasound scan can help in diagnosis but do not delay referral. Definitive diagnosis is only made at biopsy. Specialist treatment depends on the tumor type and extent. Sperm banking is routinely offered in case of decreased fertility due to treatment. Risk factors are for testicular cancer: undescended testes, bilateral undescended testes 10 times increased risk, past history of testicular cancer 4 times increased risk. Presentation: either they present as a painless lump, occasionally testicular pain will be present, hydrocele may be present with metastasis, back pain or dyspnea will be present if there is metastasis. Management: testicular lumps are tumors until proven otherwise. Refer for urological urgent urology opinion. Ultrasound can do diagnosis but do not delay referral. Definitive diagnosis only made at biopsy. Specialist treatment depends on the tumor type and extent. Sperm banking is routinely offered in cases of decreased fertility during treatment. Children conceived by men treated for testicular cancer are not at high risk of congenital abnormalities. Not at any increased risk of congenital abnormalities. Empty scrotum. If a scrotum has never contained a testis, it is hypoplastic. If the scrotum has contained testis in the past, it is normally developed but empty. Testis in the past, it is normally developed but empty. Causes of an empty scrotum: undescended or retractile testis, surgical removal, example for torsion, trauma or tumor, testicular atrophy, example due to mumps or trauma, ambiguous genitalia, testicular agenesis, diagnosis of exclusion. Types of types and features of testicular cancer. It could be a seminoma or a teratoma. A seminoma 60% cases, 30 to 40 years age group. Teratoma is less than 30 years age group. Tumor markers: there is none for seminoma, whereas for teratoma, beta HCG, AFP, LDH correlates with volume of metastatic disease. Nature of the tumor is solid in seminoma, whereas teratoma solid or cystic components 40% occur within the seminomas. Mixed tumors are treated like teratomas. Growth and speed. Slow growing tumor is seminoma, S for S, and seminoma S, solids S is slow growing, and teratoma is a fast growing tumor, can do double in size in days. Stage of presentation: 90% stage 1 tumor confined to the testis, 60% stage 1 tumor is at presentation, tumor confined to the testis. Treatment for a seminoma: treat with inguinal orchidectomy plus radiotherapy. Relapses are treated with chemotherapy. More advanced disease is treated with radio or chemotherapy. Survival in a seminoma is 98% 5-year survival for stage 1 disease. Overall 85% 5-year survival rate is there. And for a teratoma, treatment of stage 1 disease is with the inguinal orchidectomy and surveillance of tumor markers, and 25% relapse in less than 18 months. Treatment of relapses and metastatic disease is with chemotherapy. Prognosis depends on the stage and degree of differentiation. Carcinoma of the scrotal screen. Squamous cell carcinoma or melanoma, uncommon in less than 50 years of age. Painless lump or ulcer of the scrotal screen plus enlarged inguinal lymph nodes. If suspected, refer urgently to urology or dermatology. Fournier's gangrene. Necrotizing fasciitis of the scrotal screen or the penis. Patients are usually elderly and often have a hydrocele, starts as a black spot and spreads rapidly. Early diagnosis is critical to survival. So, if suspected, admit as an acute urological emergency. Treatment is with surgical debridement and IV antibiotics. Undescended testes affects 2 to 3% of the male neonates, but most descend during the first year of life. Refer those that do not descend during the first year of life for surgical descent and fixation to avoid increased risk of malignancy and later infertility. Retractile testis, usually young boys with active cremasteric reflex, no need of treatment. Examination. Scrotum usually is well developed in retractile testis. Try to find the testis, milk it down into the scrotum. May be found anywhere from the scrotum to the internal inguinal ring. If not found or you are unable to bring the testis down into the scrotum, assume it's undescended. So we have reached the end of our renal diseases, and next chapter is musculoskeletal problems. We will continue it tomorrow, from page number 445. Thank you. Have a good day.